So once the diagnosis has been made, and, you know, for many women who were expecting to go into pregnancy and have, you know, what we would call a sort of an uncomplicated pregnancy, making the diagnosis of diabetes in pregnancy can come as quite a shock. And so, you know, women require a lot of support, they require a lot of reassurance. They often feel that it's their fault, and it's very important to highlight to them that it's not their fault. And that there are things that can be done. The most important thing usually is to do with diet, and that shouldn't come as any surprise to this audience. So as soon as gestational diabetes is diagnosed, the first thing we offer is education to women. They usually have an appointment, at least with a dietitian, to go through, you know, the sort of things that we would advise that they have less of in terms of carbohydrates, trying to make sure that they have carbohydrates that don't have a huge impact on blood glucose levels. Women also are advised about exercise, and they also have to start monitoring. So that's another blow for a woman that was expecting to have a fairly straightforward, uncomplicated pregnancy, to be told that you're going to have to start monitoring your blood glucose levels, pricking your fingers several times a day. The recommendation is to do a blood test in the morning before eating, and then either 1 or 2 hours after a meal, depending upon where you work, where you practice. And you can see that the targets are really tight. So you shouldn't really have a fasting glucose above 6 or a 1 hour above 7.8, you know, in order to ensure that the glucose levels are safe for baby. The thing I must highlight here is these glucose levels are not for the woman who is pregnant. These glucose level targets are actually aimed at protecting the baby, because if the glucose levels are high, the baby has to produce a lot of insulin, and the insulin causes problems, which we will talk about in a moment. So these targets are deliberately tight because we're trying to look after the baby as opposed to the mother. In order to achieve those targets, if diet is not adequate, then it's important that medication is started. Generally speaking, metformin is the drug of first choice, but if metformin is not sufficient, then insulin will be required.
I think, you know, there's a hugely important message here that we all would aim to do the best we can for babies. And we would only do things that are safe for babies. And when we talk about tight targets of blood glucose level being safe for a baby, I think it should speak to us about what can happen to bodies if the blood glucose levels are higher than that. Do you know what I mean? So although we're talking about pregnancy, we're talking about, you know, having a healthy, safe pregnancy, healthy, safe delivery, and healthy, safe baby. There's another message here that actually high blood glucose level is just not good for you. You know, if it's so important in pregnancy, it's actually important for each person who is at risk of developing diabetes or living with diabetes. So yeah, really widespread, important message there, I think.
This just gives us an idea of why it's so important that we control the blood glucose levels in the mother. I'm sorry this doesn't project particularly well, but what you have to consider as a mother carrying a baby, it's your blood supply that is providing the nutrients to the growing baby. Now, if as a mother the blood glucose levels are too high, the medication that you as a mother takes to control your blood glucose levels does not go to your baby. So if you're taking metformin, if you're injecting insulin, that medication does not affect your baby. And that's one of the things that women worry about when we tell them that they have to inject insulin. The first thing they say is that insulin going to harm my baby? And we have to say that no, the insulin that you're injecting goes nowhere near your baby. However, your baby is very clever. Your baby makes its own insulin, but unfortunately the baby makes more insulin than it actually requires, and that is what leads to babies becoming bigger than they need to, because they start laying down fat around the liver becomes enlarged, and so the weight around the baby's tummy becomes enlarged, and that is when we get what we call macrosomia, or large for gestational age. Again, I'm sorry it doesn't project very well, but these two images, these babies are both the same age. But you can see that the baby on the left is chunkier, chubbier, redder. This baby had what we call macrosomia, which is not good. This is because the mother's blood glucose levels during pregnancy were too high. The problem with a large baby is that it's quite difficult to deliver a large baby. It can have problems during delivery, which might cause birth injuries. There is a condition called shoulder dystocia, which is actually an obstetric emergency, where the shoulders of the baby can get stuck in the birth canal. Again, because of the weight that has been put on around the baby's tummy. And this requires a very sort of skilled manoeuvring by the obstetric team on call to help deliver that baby safely. So it's really important to try to avoid that. And of course, having a big baby means that not every woman is able to deliver that baby vaginally, and therefore there is a much higher chance for caesarean delivery. The other complications are the same as for any woman with diabetes and pregnancy, including increased fluid around the baby, preeclampsia. I've already spoken about delivering early, but the one that is hugely distressing is the possibility of an intrauterine death. Women with diabetes are at a higher risk of intrauterine death, where the baby dies suddenly towards the latter stages of pregnancy. It's not clear why this happens, but it's more likely to happen if the diabetes is not well controlled during the pregnancy. And that's why we do everything possible to ensure that a woman has good control of diabetes throughout the pregnancy.
I mean, it's so important. You're going to go on to talk about all the members of the team that need to be involved to ensure the best possible outcome for the woman, for the baby. It's hugely distressing to think of any of those complications really occurring, from miscarriage, as we mentioned earlier, any of these complications. Polyhydramnios can be really uncomfortable. That's where the excess fluid around the baby, that can be really uncomfortable for the woman who's pregnant. So, it's what we are absolutely resolute in is that we want to avoid any potential complications for the mother and for the baby, for the family, and do whatever we can as healthcare professionals and for the community of people who are living with diabetes as well, to ensure the best possible outcomes. So the multidisciplinary team is involved because you need the expertise of midwives, dietitians, as you've mentioned before, diabetes specialist nurses to help with things like the monitoring, the diabetes consultants like yourself, and the obstetric consultant, and us in primary care, all working together to ensure the best possible outcomes. We know that this will involve very close monitoring, and monitoring of that woman is going to be much closer than it is for a woman who doesn't have medical conditions. Be mindful always that you want to protect her mental health as well, because as you mentioned, Dr. Akinsola, it can be a shock to a woman to develop gestational diabetes, and it can add extra challenges to the challenge, if I can call it that, of pregnancy. So it's really important that we all together as a team work for the best possible outcome. So I wonder if you would like to give us some tips for women who might be at risk of developing this condition, and give us your tips for women who are living with type 1 or type 2 diabetes, and share your expertise with us.
So lifestyle. It's all about managing diet, managing weight, keeping active, having regular monitoring. Certainly, following delivery, women should have a blood glucose level checked. This can be a fasting plasma glucose or an HbA1c. And the targets or the diagnostic targets will be very similar for people that have that aren't pregnant. It's important that if diabetes is obviously diagnosed, this needs to be confirmed, and if it's in one of the intermediate ranges, then these women do need to be closely monitored and offered usually annual testing for diabetes. It's really important that if they're planning any subsequent pregnancy, they should be checked for diabetes prior to becoming pregnant and offered an early glucose tolerance test during the early stages of pregnancy, so that if they have developed pre-existing diabetes prior to becoming pregnant, that can be picked up early, they can start monitoring and be commenced on appropriate medications. It's really important to remind women that they have a risk of developing gestational diabetes in a subsequent pregnancy, but very importantly, their risks of developing future type 2 diabetes can be between 50 to 70% over a 5 to 10 year period following that birth. So this is a really important group of women who we can actually encourage to try and do everything possible to minimise or postpone that risk of developing diabetes, mainly by just focusing on healthy living, healthy lifestyle. It's also important to highlight to women that because they've had gestational diabetes, it does put their baby at risk, their child at risk of future obesity and future diabetes. So I think as a mother, we are responsible for the health of our children and also trying to ensure that we plant healthy messages, healthy lifestyle options to protect the health of our babies as well going forward. So I think what I would just like to end by saying is that preparing women for pregnancy, if you have type 1 or type 2, is hugely important and involves every single one of us as healthcare professionals, but also the woman living with diabetes. It's really important to have good control even ever before you think about becoming pregnant. It's important to remember that women with type 2 are often older, they're often from ethnic minority groups. We need to seek them out and offer them the support that they need to ensure that they get themselves adequately controlled, prepared for pregnancy. It's important that women with gestational diabetes are adequately looked after during pregnancy to ensure a good outcome for themselves and their babies, and very importantly, to support them in the postpartum period to ensure that we continue to emphasise the need to maintain healthy lifestyle to prevent them developing diabetes in the future.
Wonderful.
Thank you very much.
Wonderful. Thank you very much, Dr. Akinsola. Thank you.